So, ma'am, good evening, ma'am. We are starting, ma'am. Madam, we are starting the webinar today, ma'am. Ma'am, shall we start, ma'am?
Yeah, yes, challenge.
Yes. So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today's webinar is problems and solutions in first trimester. So, I would like to welcome all the participants for their interest, and I request them to post their queries in the comment box so that we can have a short QA session at the end of the presentation. And now it's time to introduce our invited speaker for the day, Dr. Gigi Selvam, ma'am. Madam has completed her MD and MMU, and Madam is currently the Director of Annai Velangani Hospitals, Tirunelveli, Tamil Nadu. And Madam has completed her MBBS in 1985 from Madurai Kamarajar University, Tamil Nadu, and the MD OG from University of Manipal, Mangalore, Karnataka. And Madam has a diploma in medical ultrasound at University of Zagreb, Yugoslavia, and MMU Inter-University Center, Dubrovnik, and Europe. And Madam's special interests are iris pregnancy, ultrasonography in obstetrics and gynecology, and social obstetrics and adolescent gynecology. Madam has various highlights like Madam is the faculty member in ICMCH since 1994 and conducting a Foxy ultrasound certificate courses since 1994. Madam is conducting reproductive medicine courses for IMA since 2009, and Madam is conducting training at Ian Donald School of Ultrasound, Tirunelveli. Madam has attended, presented papers in various national and international conferences, and she has also chaired many scientific sessions. Madam has organized several live workshops and CMEs and conducting various awareness programs among women in all ages. Madam is conducting free treatments for HIV infected women. So with this introduction, I welcome you, ma'am, and I am handovering the session to you, ma'am.
Thank you, Stalin. Good evening, everybody. I'd like to start sharing my slides. Am I audible and are my slides visible?
Yes, ma'am. You are audible, ma'am, and your slides are very much visible, ma'am.
Stalin. Okay, thank you. So first, I would like to thank God Almighty for this get together with all of you today, because we are all like, the second wave speak. And it's all sad news as we hear everywhere. And I'm so happy that I'm able to talk something which brings life to this world, this darkness. So I would again thank Shield for this initiative, the Shield Connect. And also I would like to thank the whole team of Shield, especially your CEO, and also Balaji for your special interest to make me give this talk. So with this introduction, good evening all the delegates who have joined. I will start my topic on problems and solutions in the first trimester. It's actually very interesting to know that when life starts, for all human beings, it's like so small, and it's just the cells, the sperm and the ovum join together to form a two-cell stage of the zygote, which later on grows into an embryo. An embryo starts to have a form, say at 8 weeks, it starts to have a form, and its supply of food is from this, which is the yolk sac. And then again, the embryo grows, and by 12 weeks, it is so big, and it's about 12 millimeters long. And this is the whole thing which goes on the first trimester. So this is how we, all of us, have started our life. when we started it and what we are now. So with this introduction, let me go into the topic itself. When a girl is married, a delayed pregnancy is always a welcome. And after a marriage, it's like, once the period is delayed, everybody awaited the good news. And when you say that the urine pregnancy test is positive, it is taken as a thing of pride and joy, but not, of course, for all. There are people who wouldn't like to have a pregnancy. Either it is before marriage or after marriage. But this positive UPT, the urine pregnancy test, has a lot of care and concern. And the girl or the woman who's pregnant needs a lot of TLC. By TLC, I mean nothing but tender, loving care. But sometimes what happens? The urine pregnancy test, it's weakly positive. You can see both the lines in this picture. One line, that is the control line, which is dark, and the test line, which is not so dark as the control line. So this, we call it as a weakly positive. And why do we get a test result like this in a urine pregnancy test? It is because one main reason is the cold chain is not properly maintained, and this urine pregnancy test kit is not being properly stored. The other thing is whether the HCG level is the urine is adequate enough or it is inadequate to cause this test. So when a patient comes to us with a weakly positive urine pregnancy test, what do we say? We say she could be pregnant because the UPT shows a positive line on the test area. Not only that, but it is not so dark. So again, are we very sure whether the patient is pregnant or not? So what is the next thing we are going to do? That is to confirm a normal pregnancy. The next we do is a beta HCG levels, and then we go for an ultrasound, and then we go for a clinical examination. The clinical examination is not as what it was before. We are more at this present scenario, more oriented with the beta HCG levels and ultrasound, because the young women or the young mothers now don't allow us to do a per vaginal examination, and we defer to do it. Therefore, the clinical examination has a very little role to play, whereas beta HCG and the ultrasound is what we mainly rely on. So the diagnosis of pregnancy is first with amenorrhea. They become amenorrheic. Then they may have symptoms like morning sickness, which is nausea and vomiting early in the morning or any time of the day also sometimes. They feel tired and weak. They feel like they are drowsy. They want to sleep. Next, they may have a feel of dizziness and fainting, headache sometimes, pain and enlargement of the breast. This is because the breast, being a second reproductive organ of a woman, it enlarges itself so as to feed the baby when it is born. So this enlargement starts as early as when the pregnancy is diagnosed. So the breasts start enlarging and they complain of, and this causes a minimal pain. So the pregnant girl or the pregnant woman comes to you and tells that her breast feels, she feels heavy in the breast and it is hurting. All you have to do is to ask her not to wear her regular brassiere and go in for a brassiere which is larger than that. The next symptom, which can be there, some people will go for constipation, where you have to tell them to take plenty of water and also a fibrous diet. Sometimes a urinary irritability is also there, but this has to be taken into special consideration, and we have to do a urine routine and a urine culture and sensitivity. Why this? Because urinary tract infection in early pregnancy can cause abortion. This is one of the commonest condition which can cause an abortion. Therefore, urinary irritability has to be given special care for treatment. So this is a small video clipping which shows how the fetus grows to become from an embryo to a fetus like this. So here you can see this area of this cream color, that is the amniotic sac, and the thin from the amniotic sac to this red area, that is the chorionic cavity, and you have this white structure, which is the yolk sac. We'll go again this. So you can see how big the yolk sac is initially and how it shrinks in its size, because it gives the nutrients to the embryo which grows inside the uterus. And then this area, that is where the chorionic frondosome is formed. This is the area of chorionic frondosome, which later on forms into the placentae. So it is Sir Ian Donald who says that we are particularly interested in studying the first 12 weeks of fetal development, as it's surely the most critical period of existence of the fetus. So we have to take this first 12 weeks, which is the first trimester, very seriously in consideration. So has to face the problems, correct it, so that the pregnant woman would have a full-term fetus, which she is able to deliver after 38 weeks. So here the main angle which we have to do this is the ultrasound. And this is the ultrasound picture where we see a small sac here, which is the pre-embryonic sac. It is a small hypoechoic area here. And this is seen in the eccentric part. It is not in the center. It is eccentrically placed in the endometrium. The next, as it grows, you have a good gestational sac, which is tear-shaped, as you see here, and you can have a yolk sac, which is here. So you can see the yolk sac, which is available here, and a tear-shaped, nice gestational sac, which means the pregnancy is going on fine. Then again, you can start measuring the gestational sac to know what is the mean sac diameter and the age of the pregnancy. Moving on from that, the next thing you see is it's the fetal pole. The fetal pole is visible, which is the embryo, and you can measure the fetal pole to say what is the age of the fetus. Moving on, then you can see how the amniotic cavity increases in size and the chorionic cavity decreases in size, and the yolk sac, which is extra amniotic, and it is only the embryo which is seen down there, is intra-amniotic. So the yolk sac is extra amniotic and the fetus is intra-amniotic. And later on, as the amniotic cavity increases in size, the amnion, which you see here, and the chorion, which you see here, joins together. So the amnion, the embryo lies entirely in the amniotic cavity. The yolk sac lies in the chorionic cavity. The fluid within the gestational sac moves from the chorionic cavity into the amniotic cavity. The chorionic cavity diminishes progressively and the amnion fuses with the chorion. This is what happens nearly about 9 to 10 weeks, and by 12 weeks it is completed. Thereby the chorionic cavity is obliterated. So next thing what we have to do is know the dating of the pregnancy, which is how old is the embryo. And the best thing to do this is the crown rump length. It is in the first trimester. We should do this measurement from the crown to the rump of the fetus. And this is the best measurement. So later on, if you are seeing the patient at, say, at 28 weeks, 29 weeks, don't go and change the dating. The dating, if the patient had a transvaginal scan at the first trimester and she had dated what is the age of the fetus, that cannot be changed further, because only then we'll be able to diagnose either the fetus is small for gestation or it has got a fetal growth restriction. Therefore, the CRL, which is done in the first trimester to know the age of the fetus, is very, 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 very important. So looking on to the gestational sac, the important features to look at the early pregnancy is a double decidual sac sign, which has two concentric echogenic rings surrounding at least a part of the gestational sac, a continuous hyperechoic rim of at least 2 millimeters in thickness, spherical or ovoid, that is, can be tear-shaped, without marked angulation. And the growth of this gestational sac is about 1.2 millimeter per day. So this is what you see here. You can see a double sac sign. There's one here and the one outside that. This is known as the double decidual sac sign, and this shows that the pregnancy is quite healthy. If you're able to see a good double sac sign, double decidual sac sign, then you can, like, assure the patient that she's going to have a very healthy pregnancy. How is this double sac sign? Coming on to this picture, you can see this is the gestational sac, and it has got embedded into the decidua. The decidua, where it has got stuck to the endometrium, myometrium of the uterus, is known as the decidua basalis. This is decidua basalis later on forms the chorionic frondosum, which later on forms the placenta. The other decidua, which covers the gestational sac, that is called the decidua capsularis. And here you have the decidua paritalis, which is on the rest of the myometrial area. So this area between the decidua capsularis and the decidua paritalis is filled with some fluid. And this is why we have the double decidual sac sign, which means the decidual reaction with the embryo is really good, and the embryo is well fused with the uterus. Thereby, the nidation is very good, which prevents an abortion. So what is a pseudo-gestational sac? This is usually seen in an ectopic pregnancy. Here we don't have the decidual reaction as we saw there, and there is no nidation. Therefore, it is a single echogenic layer of the decidua which surrounds the intra-endometrial fluid collection, which you see in this picture here. And therefore, this is called the area stellar reaction. Therefore, a pseudo-gestational sac doesn't have a double decidual sac sign, whereas the otherwise it is seen. So the embryonic period is only up to 10 weeks of the menstrual age. As you see here, it is only up to 10 weeks. After that, it becomes a fetus. The embryonic period, the embryo is about 30 millimeter long. This is about 30 millimeter long. That is 3 centimeter long. And the BPD is about 12 millimeter long. This is what the fetus reaches when it becomes, when it starts being a fetus from an embryo. So growth of this zygote by TBS, how can we see it? This is just a tabular column to tell you the relationship between the embryology, the ultrasound, and the serum HCG. So the patient is, when she is 21 days of her last menstrual period, number of weeks from her LMP is 3 weeks, only when the blastocyst is adherent to the endometrium. And by ultrasound, you can see only the endometrium, and the serum HCG level does not rise. But at 24 weeks, when she is 3/7 weeks, the blastocyst is embedded into the endometrium. Again, by ultrasound, only the endometrium is seen, and the serum HCG level starts rising. That is about 26 to 200. At the 28th week, when she is going to expect her periods, either she gets her periods or she'll miss her period, then the week is 4 weeks from the LMP. The blastocyst again is embedded inside the endometrium. That is, it goes inside, it is covered by the decidua capsularis. And but you see only the endometrium, and the serum HCG is about 500. At 32 weeks, 32 days, or 32 days when it is 4/7, the blastocyst becomes a trilaminar disc. When you see the early intradecidual sign, that you see a small hypoechoic area eccentrically placed in the endometrium, the serum beta HCG level is about 1000. At 35 days, that is 5 weeks, the blastocyst starts seeing the embryo. So first what you see the gestational sac, then you see the yolk sac, and then you see the embryo, and you have an intradecidual sign with an yolk sac, and the serum beta HCG is 2000. By 42 weeks, this is when we call the patient to come for a scan to confirm the position, the number, the viability, and the age of the embryo. Then you can see the embryo, it is about 2 millimeter, the gestational sac is about 10 millimeter, and the serum beta HCG is about 11,000. At 49th day, that is at 7 weeks, you can see the embryo. The embryo is about 8 millimeter, the gestational sac is about 18 millimeter, and the beta HCG is about 45,000. And by 70, that is at 10 weeks, the embryo is about 31 millimeter, the gestational sac is about 41 millimeter, and it is about 100,000 beta HCG international units. So this is how the embryology, the ultrasound and the serum HCG can be correlated depending upon the age of the embryo. So now we have seen what is the normal thing which happens in the first trimester. And with this knowledge, let us go into the problems of the first trimester. So first trimester, the first thing is the patient wants to confirm the pregnancy, where you do an UPT, a beta HCG, an ultrasound. And when there is a problem, they again land up with you. So first thing they come with to you is a lower abdominal pain or a bleeding PV after a period of amenorrhea. They can have giddiness, they can have loss of appetite, nausea, vomiting, and sometimes headache. So it is with these complaints they come to you when you have to see what is the problem with the present pregnancy. So physiologically, the patient will feel a heaviness in the lower abdomen, and she would complain of a lower abdominal pain. So what is this pain all about? This is because of the round ligament stretch. The round ligament holds the uterus anteverted on both sides, and because of the stretch of this round ligament, she may have a little pain as the uterus enlarges as the fetus grows. So this is very common in the primate, and they say there is a pulling pain in the groin. There's nothing to worry about this because it is just a physiological, tolerable lower abdominal pain, and all that the patient wants it is reassurance. So what are the causes of bleeding in the first trimester? The first thing is abortion. The second thing, it could be an ectopic pregnancy or a hydatidiform mole. These are the common things which can occur. We can just see them one by one. The first abortion is like if the patient has a bleeding, it is a threatened abortion. This is defined by the WHO as a pregnancy-related blood vaginal discharge or frank bleeding during the first half of the pregnancy. But the thing is, they don't have any cervical dilatation. The cervix is closed, and they would have a lower abdominal pain. This occurs in 25% of the pregnancy. The ultrasound will show a viable fetus. The fetus would be showing a heartbeat. The beta HCG level would be normal, and you can check on the maternal health also. And don't forget to see a RH factor, because if it is negative and if the partner is positive, then the patient should have a low dose of anti-D, that they should have 150 micrograms of anti-D injection because of this threatened abortion. So what is the pathology of this abortion? First, we were talking about the Decidual basalis. As you see here in this picture, the hemorrhage is into the Decidual basalis. There is a necrotic change and with the tissue adjacent to it. Therefore, the conceptus which wants to get nidated into the myometrium gets detached and it is separated, which stimulates uterine contraction. So its uterus starts contracting. This is why the patient has got bleeding, not only bleeding, but also abdominal cramps during this time, which results in expulsion of the fetus. So the early pregnancy failure, the task is by ultrasound, which confirms this diagnosis. Prior 20 years, 30 years, 35 years back, when ultrasound was not there, it was very difficult for the practicing obstetricians to know what is happening. All they knew was a bleeding. They would do a PV and they would say whether the cervix is dilated or not. So it is now with this ultrasound, we are able to confirm the diagnosis, either whether it is a complete abortion, incomplete abortion, whether there is an embryonic demise, whether the heartbeat is there, whether it is a blighted ovum, intrauterine hemorrhage which has occurred, a molar pregnancy, an ectopic, or anything else which is miscellaneous. So it is the task of the ultrasound to tell us what have happened. So what are the signs of a failed pregnancy? Whether when the sac is irregular, as you see in this picture, when you have an abnormal yolk sac, which is less than 2 millimeters and more than 5.6 millimeters when it is hydropic, when the fetal growth is not adequate, and when there is a subchorionic bleed, which is seen, which is more than the gestational sac. As you see here, there is a bleed here, which is more than the gestational sac, more than 3/4 of the gestational sac. Then also it's a failed pregnancy, and when there is no cardiac activity seen in the embryo. So first thing what can happen is the whole thing can get expelled when it's a complete spontaneous abortion. The absence of the gestational sac and the presence of the intrauterine debris are typical of the complete abortion, and that can be seen. The next thing is inevitable abortion. Here you can see this is the level of the internal loss and the fetus is expelled out from the uterus. This is the uterine cavity and it is expelled out, as you here also you can see. So here the difference between a threatened abortion and an inevitable abortion is here the cervix is dilated and you can almost feel the fetus, the products of conception coming out through the cervix. So we'll have some cases which we can discuss to find out what are the things, what we are going to do, what is the solution we are going to take. First is here you can see a normal fetus. It is an intrauterine pregnancy. You can see a nice round yolk sac, normal size. Usually they are 4 millimeters, and you can see the embryo there. And you can even watch the embryonic heartbeat. Here you can see the embryonic flicker. That is called the embryonic heart flicker, which you can see. So with this, we would like to say the differential diagnosis as a normal intrauterine pregnancy, because this pregnancy had a fetus, it has a nice amnion and it has a chorion. The chorionic frondosome is being formed here, and you can see the yolk sac also. So it is a normal intrauterine pregnancy. But though this is a normal sonogram, the risk of having a spontaneous abortion is 9% from 6 to 13 weeks. And the abortion rate is more after 10, 11, and 12 weeks, because that is the transitional period when the chorionic frondosome becomes a placenta. As the placenta is forming, there is always transition is always very difficult in all process of life. Therefore, like here also, this transitional period causes a chance of abortion. Coming on to case 2, here again UPT is positive, but we have no ultrasound sign of pregnancy. As you can see in this, you can have a nice midline endometrial line in this uterus, and you can see that the cavity is normal and you don't see any pregnancy there. And the adnexa is also normal, as you see here. So what is that we have to do here? It could be a normal early pregnancy, which is not visible to us. So if you do a beta HCG, you will know that whether the patient is pregnant or not. But where is the pregnancy? All that you have to do is to wait and see how it goes. That is when you can say it is a delayed conception. So don't take a decision then itself. Tell your patient to come again after 2 weeks or so that we can check on it. And if you still want to confirm whether she is pregnant or not, then you have to tell her to do a beta HCG test. Or could it be an ectopic? It could be a small ectopic which may not be visible to the ultrasound, can also happen. So you have to tell the patient, again, we have to see where the fetus is. Is it intrauterine or it is extrauterine? So you have to ask her to come after another 10 days or 2 weeks, and then you can do a repeat scan and also a beta HCG, again, a serial beta HCG where the beta HCG level increases, shows that the pregnancy is somewhere, and you have to see it inside the uterus to say that it is a small normal intrauterine pregnancy. Or if nothing is there, you have to put a thought about a complete abortion also. In a complete abortion, the beta HCG level could have come down and there would be nothing, but still you have to take care of whether it is an ectopic pregnancy, which is a life-threatening condition. So you have to be careful, ask the patient to come for regular follow-up. So serial beta HCG is very important, and the serial transvaginal scan is also important. The third case, UPT is positive, and you can see a small embryo here, but there is no cardiac activity. What is the differential diagnosis? It's a normal small embryo, early pregnancy failure. And the comment could be when the embryonic length is more than 5 millimeter by transvaginal, or by when the length is about 9 millimeter by transabdominal, you should be able to see a heart flicker. But if you don't see it, you have to think about it. The case 4, here you can see an extrachorionic fluid collection, and that is the embryo. So what is it going to show? An extrachorionic hematoma, here as you see here, or it is a prominent venous lake. The venous lake, if you switch on your Doppler, you'll be able to see. but there must be a judicious use of Doppler in early pregnancy, or it could be a threatened abortion. So vaginal bleeding is present. The venous lake has to be ruled out with the Doppler. So again, the size of the clot is what that matters. Small clots, less than 50% of the sac circumference, the miscarriage rate is only 9%, whereas a large clot whose volume is more than 60 mm and more than 50% of the sac circumference, the miscarriage rate is high. It is about 18%. And again, the presence and absence of the cardiac activity is important. Here you can see the clot here, and that is the yolk sac here, and that is the amnion, and you can see the embryo inside. So this clot is a big clot, and that you have to prepare the patient that she would have to face an abortion, telling her that the fetus is not doing so well. Again, here the fifth case, the embryo is alive, bradycardia, and high risk of spontaneous abortion is here because of the bradycardia. Case 6, again, embryo alive, but you can see there is no fluid here. Are you able to see here? There is no fluid surrounding the embryo, which is oligohydramnios. And this is associated with increased spontaneous abortions. Not only that, you have to look for anomalies like chromosomal anomalies or aneuploidy in these type of cases. So a small gestational sac is related to the size of an embryo. A small gestational sac where the MSD minus CRL, if it is less than 5 millimeter, or the outcome is bad. It is an abnormal outcome, which is about 70 to 95%. So we should know what is the prognosis of this particular patient, and you should be able to convey it to your patient to tell them what will be the end result and prepare them to face the eventuality. The next is the missed abortion. This is a fetus without heart or limb motion, which may still remain in the gestational sac. The patient won't have any bleeding, but when you do a scan, the fetus is here. And by the standing joint commission, by TVS, when an embryo is greater than 6 millimeter in length and no evidence of cardiac pulsation, this is suggestive of missed abortion. We have the next thing, which is called the blighted ovum. The blighted ovum is an embryonic sac, which is the gestational sac is empty. You don't see anything, but you see a gestational sac. And this is again by the standing joint commission. When a TVS is done, the sac diameter of greater than 20 millimeter with no yolk sac on embryo is suggestive of a blighted ovum. Blighted ovum is a diagnosis which happened only after the advent of ultrasound. Before that, we never knew that there is a pregnancy without an embryo, without an yolk sac. It is only after that this entity came into vogue. So definite diagnosis of criteria for intrauterine pregnancy failure. It's a time-based criteria because we have to see the embryo growing. That's why it's a time-based criteria. So the gestational sac should be seen at 5 weeks, the yolk sac at 5.5 weeks. We have already seen this. The embryo with a heartbeat at 6 weeks. There could be a half a week, that is 3 or 4 days change because of the inter-observer variability. Because if I do a scan or my colleague does the scan, there can be a change about 3 or 4 days between the observers. If the gestational sac with the yolk sac is seen, first you have to see it at 5 weeks and the embryo will be seen at 6.5 weeks, which is about 1.5 weeks. So when are you going to ask the patient to come again? That is after 11 days for the next scan. So rescan after 11 days. But if the gestational sac has not got no yolk sac, and that's the gestational sac at 4.5 weeks, but the embryonic heartbeat is 6.5 weeks only, you can be able to see, including the inter-observer variability. So 4 plus 6.5, that is 2 weeks. So if you just see a gestational sac with no yolk sac, you ask the patient to come after 14 days for a rescan. So this is how you have to ask your patient what to do when, and don't ask them to come for frequent ultrasound. Case 7, it is the endometrial cavity. You all know it's filled with tiny cysts, which is hydatidiform mole, or it could be a partial hydatidiform mole where you can see the hydatidiform mole particles here. This is the cystic space and you have a normal embryo here. This again should be suspected and followed up very closely because they can lead to choriocarcinoma. Therefore, the differential diagnosis would be a molar pregnancy or a vesicular mole or a hydatidiform mole, which could be complete, which could be partial. You have to think about gestational trophoblastic diseases in mind. So choriocarcinoma also comes in it, or sometimes it could be an incomplete abortion too. And the Doppler and also a serial beta HCG has to be done. And the patient has to be instructed properly not to become pregnant for the 6 months thereby to rule out or to treat choriocarcinoma, which we do see in some cases. Coming on to the 8th case. So you can see this clipping where you can see that how the uterus is, and you don't see a gestational sac inside the uterus, but you can see a gestational sac outside the uterine area. Are you able to see here? You're able to see a small. So the live embryo is outside the uterus, no evidence of intrauterine pregnancy. Echogenic extrauterine mass is seen adjacent to the ovary. Fluid is in the pouch of Douglas if there is a rupture. This is an unruptured. Again, unruptured can be medically managed, whereas a ruptured would need a laparoscopic exploration and clearance. Again, it is an ectopic pregnancy. You can do a beta HCG, and when you put a Doppler, you can see the nice ring of fire. We do this only in the case of an ectopic. So prediction of prognosis is very, very important. That depends on the size and shape of the gestational sac, the chorionic frondosome, the yolk sac, the fetal growth, the fluid inside the sac, the retrochorionic area for hemorrhage, and of course the cardiac activity. And we have a small new thing which has come into vogue, that is the chorionic bump. What is this chorionic bump? This is an irregular convex bulge which is seen into the gestational sac. And this is from the chorionic decidual side of the fetus, which is into the early gestational sac. This is nothing but a hematoma, which is formed from the chorionic frondosome area and is seen in 0.4%. It is about 73 cc. And this chorionic bump, if it is seen, it can lead on to abortion. So if you see a chorionic bump, it is not a good prognostic sign. The chorionic frondosome, again, you have to see how it forms into the primary villi, the secondary villi, and the tertiary villi, and forms the lacuna. So we have the first wave of invasion by this chorionic frondosome, and then the second wave of invasion to form a very good placenta. Therefore, the retrochorionic area has to be seen. Where is it located in relationship to the uterus, and is there any abnormalities? All these things should also be taken into account. The last thing is, next we have to see about the placenta location. In the first trimester, never say it is a placenta previa. All you have to say is a low-lying placenta, where you have to tell your patient that she cannot carry heavy weight. As you see here, this is the cervix. You have a low-lying placenta. And in the second trimester, again, it's a low-lying placenta. The third trimester, you can see how the placenta, this is the level of the internal loss, and how the placenta covers the level of the internal loss. The fourth thing is you can measure the distance between the internal loss and the placenta. That is the lower uterine segment which is formed, and you can see whether you can leave the patient for a vaginal delivery or take her up for a cesarean section. So ultrasound is the criteria to know the failed pregnancy. You have definite diagnostic criteria, which is size-based to know the growth, and also the time-based. And you can have suspicious criteria for a failed pregnancy. So to put everything into a nutshell, the uterine sonogram gives us the answer for all these problems, where you see a gestational sac inside the uterus, or you don't see a gestational sac, where the mean sac diameter is more than 20 mm, at less than 20 mm, and there's no embryo, you have to follow up with a sonogram. If there is an embryo, you have to look for the embryonic heartbeat. If it is present, the prognosis is very good. If it is absent, again, you look for the CRL. If it is less than 6 millimeters, you can follow it up with an ultrasound. If it is more, you are dealing with no heartbeat, you are dealing with a dead embryo. If it is more than 20 millimeter and you see no embryo, then it is a blighted ovum. Coming on to no gestational sac, you do a beta HCG. If it is less than 2000, you follow up both with ultrasound, transvaginal, and also HCG. If it is more than 2000, what you can do is it's a probable ectopic, or it can be a complete abortion. Next, a word about placenta accreta, because we do see a lot of them where the placenta is adherent to the myometrium. The myometrium thickness is only 1 millimeter. There is a loss of a clear space between the myometrium and the placenta, and an increased level of PAPP. So we have a scoring also by ultrasound, where you can suspect a placenta accreta, thereby you can be alert with that. So this is one study which was done with 400 5,670 deliveries, the patients without placenta previa, and about 9.3% of the patient with placenta previa, and 2% of patients who had no cesarean section more than 35 years. But the last thing, the 39% of the patients more than 35 years with 2 cesarean sections. Next, we have to be very careful about the cesarean scar pregnancy, which is increasing now because of the increased incidence of cesarean sections. This is a challenge to us. This is seen in 6.1% of ectopic pregnancy. We have a negative organ sliding sign. A Doppler imaging, if you're going to do, the peak systolic velocity is more than 20 centimeters per second, and the PI is less than 1. If you see that and a lower placed gestational sac close to the cesarean scar in the lower uterine segment, don't miss on this diagnosis because this can cause a lot of problems. Don't forget the local lesion like vaginitis, ulcer in the external genitalia, cervical erosion, cervical polyp, and malignancy of the cervix. So this algorithm might help you. Early pregnancy with pain and bleeding, you do an ultrasound, intrauterine pregnancy, expectant management. If it is not inside the uterus, an ectopic pregnancy, so you treat the ectopic. The next is if you have an abnormal intrauterine, expected management that you either do a DNC or a intravaginal misoprostol. Non-diagnostic, repeat with a beta HCG, discriminatory zone, no intrauterine pregnancy, evaluation of the uterine content, and then you look if there is a chorionic villi or not. If not, you can treat it as an ectopic. If there is a chorionic villi, what is the abnormality like in an idatidiform mole? If beta HCG doesn't show a discriminatory area, then do a serial beta HCG and depends on the abnormal rise or fall, whether it increases or not, you have to evaluate the uterine consent. A normal fall, there is no treatment because there's nothing inside the uterus. This algorithm will help you to go about with the early pregnancy with pain and bleeding. And if there is a normal rise, you can look into the ultrasound where beta HCG is seen, and then you can go and treat it as a normal intrauterine pregnancy. This is how you treat it. The next thing, along with this, what we can do is we can do a cervical length, thereby to prevent a preterm labor. As you see here, this is a nice cervix. The length of the cervix should be more than 3 centimeters. And you have an ultrasound elastography of the cervix where you can see the cervix. Here, the red area shows it's a soft, whereas the dark blue area is a firm cervix, and also the green area shows in between. So you can do a color elastography also if you have a high-end machine to see whether there is a cervical softness or a cervical problem. The other things than the gestation sac, don't forget to peep into the adnexa. That is very, very important, as this adnexa cannot be seen in the later trimesters because the uterus will be large and it will not show the adnexa. The main thing is you have to look into other abdominal organs also, because if the patient comes to you with a pain abdomen, you may not know the reason why this pain abdomen. Therefore, you have to take care to rule out the cause of pain. As you see in this picture, there is an ovarian cyst. So if you see this ovarian cyst in the first trimester itself, you can make a note of it. Or if there is a fibroid, all these things can be noted down in the first trimester, because as the fetus grows, you may not be able to see them because of the enlargement of the uterus. The mini anomaly scan, which is the first trimester screening, which we screen for aneuploidy, and we also do a double marker. Here you can see the nasal bone, which you measure also in the end of the first trimester. Doppler application after 11, that is when you do the NT scan. You can do it for the ductus venosus for aneuploidy screening, detection of structural anomalies. A preeclampsia screening also can be done in the first trimester, where you can do a uterine artery flow Doppler. So the thing is, you cannot abuse the Doppler. The Doppler should be avoided in the first trimester. You cannot put the Doppler on just to show the fetal heart to the patient. No, you have to do it only in the M mode, because the heating effect can destroy the embryo. Not only that, recent studies correlates this with autism also. The ring of fire can only be seen in an ectopic pregnancy as seen in this picture. Therefore, Doppler can be of very minimal use during the first trimester. PIH can be diagnosed with a combined screening, the maternal risk, the arterial medial mean arterial pressure, rollover test, the uterine artery Doppler as you see here, and also you can do a pentamarker, that is the biomarkers of PAH, where the PLGF, which is there, will let us know whether this patient is prone to have a PAH, and she can be started on a low dose of aspirin, which is not 75 as it was previously given. Now it is 150 milligram at bedtime is what we advise. Before I just close my talk, I would like to talk about the chorionicity in the twin. Here you can see, because chorionicities cannot be fixed up at the later age, it can be only done in the first trimester. Therefore, here you can see this is a dichorionic diamniotic because it has got a lambda sign. But here you have a T sign, which means it is a monochorionic monoamniotic. Here again, you can see one fetus is growing, one embryo is growing well, the other embryo is small. That is a discordant growth of the embryo. Or you can have a triplet also like this, where you can see what is it? It's a lambda sign here showing this is a dichorionic diamniotic, whereas it's a T sign here. As you can see, it's a T sign here, where this is a separate embryo. So you can see this, we can see all these multiple pregnancy. This is like, you can see 1, 2, 3, 4, 5, 6, 7 sacs. This is all because of the assisted reproductive techniques where they put in a multiple embryo, which results in such type of multiple pregnancies. And this is again has increased because of the ART procedures. So early pregnancy outcome, if you tell, the viable intrauterine pregnancy is only 84%. The non-viable is about 15%, that is 10 to 20%. You have an ectopic, which is 1 to 2%, and a hydatidiform mole of 0 to 1%. This is the outcome of a intrauterine pregnancy. But you should always think the first trimester bleeding proclivity gives a risk of abortion, a risk of aneuploidy, risk of developing preeclampsia, preterm, and also PROM, and also placental abnormalities like placenta accreta can all be made. And this study proves that is threatened abortion is a risk for poor pregnancy outcome. So whenever a pregnant woman has a problem in the first trimester, she's not always going to have a problem. So you have to take it very seriously. Any first trimester problem, you have to take it very seriously, and you have to index this pregnancy. So the first pregnancy problem has to be noted. 90% of them will be in problematic pregnancy till the end. And it is your care which gives them a good fetus, and the mother and the child have to be healthy, which requires more stringent antenatal care. And these pregnancy have to be indexed, and extra care has to be given. And you have to pick up the complication as earlier as possible to prevent and also to avoid the complications. And you can refer it, if necessary, to a higher center too. So the antenatal care, which was a pyramid like this, when there was a minimal care at the starting of the pregnancy and you have a maximum care, this was what was happening a decade ago, but now it has become something like that, where it is upside down, where you give the maximum care in the early pregnancy, that is the first trimester. And you all know why we have to give the maximum care during the first trimester. So with this, if you have any, I complete my talk, any suggestions, any queries and doubts, I'm here to clear it. Thank
Yeah,
you.
thank you. Yeah, ma'am. Thank you, ma'am. Thank you for that wonderful presentation, ma'am. All the cases which you have presented were really interesting, ma'am. And ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I will read out for you.
Okay, Stal.
Ma'am, I personally have one question, ma'am. Like you have mentioned about this cesarean scare pregnancy, ma'am.
Yes.
Whether the risk is more when the couple is planning for immediate birth, or if there is some timeline between the next first baby and second baby, the risk will be reduced. What will be your comment, ma'am?
There is no study like that to say. It is only that some fetuses like low-lying fetus, some placenta previa, like what you see here, some pregnancy, that is, I told you 6% of the ectopic pregnancy, they go and get stuck in the lower segment cesarean scar area. There is no correlation between the time of the pregnancy. The interval time is, there is no correlation.
Okay, ma'am. And ma'am, what will be the risk factors which triggers this early pregnancy loss, ma'am, and how to overcome it, ma'am?
The risk factors again depends on the individual. We have to take what are the maternal risk factors, obesity, whether she's what is the work she's doing, is she exercising even during her pregnancy, whether she is diabetic. Diabetes again can cause abortion, whether she has got any other problems like SLE, all those collagen diseases have to be taken into consideration. Therefore, only when a mother is healthy, she would have a healthy baby. Therefore, maternal causes like thyroid, all these things have to be ruled out before she becomes pregnant. The HbA1c level, because diabetes is very rampant in our country, HbA1c level should be less than 6 to have a healthy baby. Otherwise, they will have an abnormal baby. That has to be considered. And then again, the fetus, the health of the fetus, as I've all enumerated, all these things have to be considered.
Okay, ma'am. Ma'am, another question like in how to manage this COVID in first trimester, ma'am? How to overcome those situations and whether vaccination is safe in first trimester, ma'am?
Vaccination has not been in pregnancy itself has not been opened in our country, but vaccination can be given in the second and third trimester. That is what it's given. First trimester, we don't give any vaccination usually. And again, in the first trimester, actually COVID doesn't affect the first trimester, because the acetylcholine inhibitor, ACE inhibitor, 2 inhibitors, and also the transaminase enzymes, they are not usually formed in the first trimester. They are formed only in the second trimester. So COVID usually cannot harm the fetus in the first trimester because they don't reach there. Therefore, it is only, we can, at the present moment, we don't have much literature about it. Maybe we'll get it later. Whether the incidence of abortion has increased or not, we really don't know. There are few studies which have come, but the pregnancy rate has increased because of the lockdown. But the abortion rates, because there have been more of a, people wanted to do an MTP and there was a lot of MTPs being done, medical termination of pregnancy. But about the percentage of spontaneous abortion, there is no good literature paper to tell us. I can give you a strong evidence statement to say that COVID causes abortion or COVID doesn't cause abortion. I cannot say at this present moment.
Okay, ma'am. Ma'am, there are some appreciations in the comment box, ma'am. Like the presentation was wonderful and the presentation was very good.
Thank you.
So, ma'am, I don't find any of the questions in the chat box, ma'am. So, if you allow us, then we can end the webinar for today.
Dr. Stalin.
Yes, sir.
There are questions in the speaker box. There are 2-3 questions there.
Yes, sir. I will check it once, sir. I mean,
3 questions are there.
Yes, sir. Yeah, ma'am. Ma'am, we have one question like, what will be the relationship between the sperm DNA fragmentation and pregnancy loss?
Sperm defragmentation relationship with the pregnant, there will not be a pregnancy at all. That's again the problem. Because once the pregnancy has been achieved, there is not much about the abortions and the male factor. The male factor doesn't play a major role once the embryo is formed. But this fragmentation, again, it will not let a embryo to form by itself. But I read one particular paper where they say because of this, there could be a blighted ovum where it's just the gestational sac and there is no material inside it. But I don't know. I have to ask somebody and then I have to get back to this.
Okay, ma'am. Ma'am, another one question is, what will be the minimum interval to conceive after COVID vaccination?
Pardon?
What will be the minimum interval to conceive after COVID vaccination?
There is nothing of that sort. There is nothing. That's a clear. All foreign studies. There have been one study in UK, one study in US. about people being vaccinated and then becoming pregnant. One paper said like only after 12 weeks you can become pregnant, but there are a lot, the present guideline is after the vaccine you can become pregnant. There's no problems. Because the vaccine doesn't contain a live vaccine. It is either a virus-like particles, because with adenosine, like in Covishield, and the other one is, again, it is a attenuated vaccine. It's not a live vaccine. Therefore, the vaccine doesn't cause much problem. Not only that, the vaccine is very close to the influenza vaccine. The influenza vaccine, we give it during pregnancy, and we all take it every year, especially people on the front line of the health, like doctors and nurses. We are supposed to take the influenza vaccine every year. And influenza vaccine is now given at the second trimester, at say at 28 weeks, 26 weeks, we give it. And this vaccine, the Covishield and the Covaxin, both of them are similar to the influenza vaccine, so they can be given.
Okay, ma'am.
There is nothing to stop a couple not to become pregnant because of vaccination.
Okay, ma'am.
Okay.
Ma'am, we have another one question, ma'am.
Yes.
Can you have a gestational sac and not be pregnant, ma'am?
No. Your beta HCG level will be high. If you have a gestational sac and your beta HCG level is high, gestational sac is just a hypoechoic area which you see either inside the uterus or outside the uterus. And if your beta HCG level is low and it is beta HCG level is say 0.5 international units, then you are not pregnant. And this is not a gestational sac. It is only a cyst, just a collection of fluid. So if beta HCG and the gestational sac is there, it is a pregnancy.
Thank you, Dr. Gigi. It was a question from Premchand.
Okay. Premchand. Nice to see you here.
Okay, ma'am. And there is yes, ma'am.
Anything else?
No, ma'am. There is another information from Dr. Sarda. I don't know whether it's a question or information. There is no teratogenic effect with vaccination, ma'am.
Yes.
Yeah,
that's true.
Yeah, ma'am. So thank you, ma'am. I don't find any other questions in the chat box here, ma'am. And
Okay,
if you allow us, then we can end the webinar for today.
Yeah.
Ma'am, we have one more question, ma'am. We have one more question, ma'am. Like, does progestin as added advantage in managing subchorionic HCG in first trimester?
Yes. There is a role for progestin sometimes to reduce the bleeding, because if the bleeding is because of low progesterone, then it can occur. But usually in the first trimester, progesterone doesn't be produced there much. It is the human chorionic gonadotrophin which plays a major role the first trimester. But progesterone is very essential for pregnancy. That is why now in the Indian market, it is flooded with progesterone, and everybody writes a progesterone once the patient becomes pregnant. It's not necessary like that. Like a normal pregnancy doesn't need a progesterone support. But if we have to correctly, judiciously give progesterone, we have to see the serum progesterone level. And if it is low, then you can add progesterone. Otherwise, it's not very necessary.
Okay, ma'am. Yes, ma'am. Ma'am, another question from Dr. Mageshwari. COVID fever in first trimester, how to manage, ma'am?
COVID fever as any other fever, like any other COVID, if her RT-PCR is being said as positive, then she has to be treated like any other COVID patient. The patient is very important. But COVID as such, does it cause abortion? It's questionable. But fever can cause an abortion. High fever, like 101, 102, can cause an abortion. And it is because of the symptoms of COVID that could be an abortion, and not with COVID as such can cause an abortion. This is what the present literature says about COVID and the first trimester. So first trimester, the mother is very important. So again, treatment of the mother depends upon whether she is in the phase 1, phase 2, or phase 3. And no pregnant woman is given a home quarantine. The guideline says a pregnant woman should be under the care of the medical professionals. She cannot be in a home quarantine. Therefore, whether it is phase 1, again phase 2, she has to be admitted and treated. And phase 3, again, she has to be treated. The mother's life is more important than the fetus. So we don't bother about the mother much. And she might mostly abort because of the fever and the other symptoms, not because of COVID as such. That is what papers say.
So fine, ma'am.
Okay.
So we don't find any other questions, ma'am. And if you allow us, then we can end the webinar today, ma'am.
Oh, thank you. Thank you.
Thank you, ma'am. Thank you very much for being with us and spending your valuable time with us today, ma'am. And hope all the participants really found this webinar useful. So on behalf of Shield Healthcare and our team, NutriSnaps team, I would like to thank you for participation, and I would like to thank the participants for their active participation, ma'am. Thank you, ma'am.
Thank you. Thank you, one and all. Thank you, Balaji.
Thank you. Thank you, doctor. Thank you very much.
Bye.
All right. Thank you, madam.